Let's talk a little bit about the difference between oral medication and long-acting injectable formulations. So we've had long-acting injectable formulations for several decades, and they're still underutilized. I think it's something we can talk about, the extent to which we think they're underutilized, but that's certainly my impression. And perhaps one of the challenges has been that the data at times have been confusing. We look at the randomized controlled trials comparing long-acting and oral medications, and they're not always consistently showing an advantage for the long-acting injectables. And the most recent meta-analysis that we did not show a consistent advantage for the LAIs. But if you look at the mirror image studies, then the results are pretty compelling, that the long-acting injectables are superior. If you look at the cohort studies, the kinds of naturalistic studies that Jari Tahonen has done, and we published a meta-analysis last year in the Schizophrenia Bulletin looking at 42 of the cohort studies, and we did see a significant advantage for the long-acting injectable drugs in terms of rate of hospitalization and all-cause discontinuation. So I think part of it is how do we go about studying this, and how do we translate those data into communications to physicians at large and families and patients. My own personal impression is that there are enormous advantages to the long-acting injectable medicines. And as we mentioned before, just the idea that you know for sure whether or not someone is taking their medicine. If someone does have a relapse, you know that they've broken through despite taking medicine. If someone relapses on oral medicine, half the time we're not sure if they've been taking it or not. And when someone comes to an emergency room, we don't usually do a blood level to find out if they've actually got drug in their system. So I think there are a lot of clear advantages of the long-acting injectable formulations, but we still have a long way to go in terms of getting universal buy-in as to what those advantages might be.
So John, how much do you think that the underuse of long-acting injectable is related to the aversion to giving injections by psychiatrists?
So I think that may be part of it. I don't think that's the biggest part of it, because it's not always the physician who's giving the injections. It often is a nurse or a nurse practitioner, and there are many hospitals that have those personnel who are available to give injections, and some states pharmacists can give injections. So I think it's more along the lines of what prevents doctors from even thinking about this as an option. And we'll come back to that a little bit later in the discussion, but when we think about oral medications, we've talked about some of the challenges. But when we talk about long-acting injectable formulations, do you think patients have as much of a challenge in terms of continuing on them as they do in continuing on oral medication?
For people who really don't want to take medications, in the absence of some compulsion to take them, they're not going to take either kind.
And do you think there's any promise to using a behavioral economic strategy that people could be incentivized for taking medicine? There have been a couple of studies in Europe suggesting that might be feasible.
This is like contingency management, that you get paid to come and get your shot. Yeah. I think that's very promising. I think in the substance use world, that's these contingency management setups are helping people stopping use cocaine and cigarette smoking too.
So Jeffrey, you had asked about what the obstacles are. Is it really that the doctors don't want to have to give the injections themselves? I think for some people that might be the case, but I think the bigger issue is that physicians are not necessarily comfortable with or adept at having the conversation with the patient that would introduce the topic and help the patient through shared decision making recognize that this is a very good alternative for managing their illness. I think many people have assumed it's the patients who are objecting to the injections, but I think a lot of research now has shown that it's more a problem in terms of the clinical team not really providing the input. And so surveys that have been done have suggested that doctors say, well, I suggested it to my patient, but he said no. But then when the patient is asked, the patient says, well, actually no one ever really explained that to me. So I think that's part of our challenge is kind of getting the message out that this is a very viable way.
I think it's analogous. I think it's analogous to clozapine in some ways.
Very much so.
Docs think that patients don't want to do it. And then the flip side of that is it's more of a hassle for the doctor, or potentially more, and for the, so there's like, I don't think the patients want it. It's kind of a hassle for me, so I don't ever bring it up. And I think that is one way if we could change doctors' behaviors a little bit. And I think Jeff's right. Actually, I do think that it is a little bit of a barrier that docs don't know how to give shots or won't give shots. I mean, if you have a nurse that can give the shots, great. But otherwise, you got to be willing to, you got to know how to do it and be willing to do it.
That's true. But maybe we shouldn't be relying on the doctors to give injections, because is it necessary to have an MD to give an injection? And we're all very pressed for time, so maybe we need to understand how to better use pharmacists and nurses. And
if there are alternatives, that's great. But if there's no alternative, then they won't get it.
well, that becomes another challenge for the system, so to speak. So.